So imagine if your body had this hidden biological blueprint to just reverse tissue aging.
Right.
Specifically, we're talking about regenerating a thinning, estrogen-deprived vaginal wall. And, the only tool you needed to unlock it was literally a few drops of your own blood.
I mean, it sounds like complete science fiction.
It really does. But today we're doing a deep dive into the microscopic mechanics of platelet-rich plasma.
Or PRP.
Yeah, and we have a really great stack of sources today.
We do. We're looking at soaping reviews, clinical trials, and experimental studies looking at both overreactomized rat models and actual human data.
Which is key, because our mission today is to figure out exactly what growth factor signaling cascades.
Specifically looking at VEGF and TGF-beta.
Exactly. What those specific cascades trigger to regenerate the estrogen-deficient lamina propria.
Because if you or someone you know has looked into, non-hormonal treatments for menopausal changes, things like vaginal atrophy or genitourinary syndrome of menopause.
Or even pelvic floor disorders.
Or even pelvic floor disorder.
Right. You've likely heard of PRP. It gets pitched as this miraculous healing serum. But instead of just saying it heals you, we're going to look under the microscope.
Because we want to understand how your own blood can orchestrate such precise tissue regeneration.
Okay, let's unpack this. Because I am so fascinated by the sheer complexity of the body here. We aren't just talking about a magic healing serum, right?
Right. Definitely not magic.
We're talking about a highly coordinated biological construction crew.
I like that. A construction crew. And to understand what that crew is doing, we kind of have to establish the baseline of the tissue we're trying to heal.
The barren landscape, so to speak.
Yeah, exactly. In the medical literature, they focus heavily on the estrogen-deficient lamina propria.
And the lamina propria, for context, is the connective tissue layer sitting just beneath the surface lining of the vaginal wall.
Right. And to study this, researchers often use overreactomized rat models. You'll see it abbreviated as OVX in the studies.
Because by surgically removing the ovaries, they're basically inducing a sudden, severe drop in estrogen.
Yeah, effectively mimicking human menopause. And what they observe is this rapid, cascading degradation of the tissue.
Because estrogen is normally maintaining all the structural integrity there.
Exactly. Without it, the studies note this massive drop in hyaluronic acid.
And hyaluronic acid, or HA, that's highly hydrophilic. I mean, it binds to water molecules. Yeah. It's the tissue's natural sponge.
Yeah, and without that sponge, the tissue literally physically dries out. But, it goes deeper than just moisture.
The blood flow, right?
Right. The blood vessels in the lamina propria begin to retreat, so blood flow is drastically reduced. And then the extracellular matrix, which is
the structural stuff.
Yeah, the physical three-dimensional cellular scaffolding made of collagen and elastin, that literally starts to break down.
So the tissue is essentially starving for oxygen because the blood supply is shrinking. And the whole physical architecture is just crumbling.
Exactly. And what's fascinating here is how the body can be coaxed into repairing this totally barren landscape.
Enter the PRP intervention.
Right. The sources detail the exact preparation of this. It begins as an autologous concentrate.
Meaning it's made entirely from your own blood.
Right, from the patient's own body. They draw a standard sample of blood, maybe like 10 cc.
And then the studies describe using a specific gel separator system.
Yeah, they place the blood in a centrifuge and just spin it down.
So the physics of the centrifuge force the heavy red and white blood cells down to the bottom of the tube. And then the lighter plasma.
The liquid gold, some call it.
Yeah, the liquid gold, it floats right to the top. And from that, they isolate about 5 cc of highly concentrated platelet-rich plasma.
But at this point, that plasma is mostly dormant. I mean, the platelets are still intact.
Right, so to turn it into a regenerative therapy, they have to activate it.
Exactly. They introduce below 0.5 milliliters of calcium chloride right into that 5 cc of PRP.
Okay, let's talk about why calcium chloride is the trigger here. The sources say it initiates the thrombin cascade, but how does, a simple salt physically force these cells to do anything?
Well, calcium ions are basically the fundamental biological trigger for the body's clotting mechanism.
Oh, interesting.
Yeah, so when you introduce a really high concentration of calcium chloride, it perfectly mimics the chemical environment of an acute tissue injury.
So it's tricking them.
Exactly. The platelets detect this huge spike in calcium and just assume there's a massive wound that needs immediate healing.
And that kicks off the thrombin cascade.
Right. Which physically alters the platelet's membrane. The platelet violently contracts and then degranulates. It basically bursts open.
And when they burst, they release their payloads, right? The alpha granules.
Yeah, these alpha granules are just microscopic sacs packed with growth factors. And because we spun down the blood to concentrate the platelets in the first
The
place,
concentration is huge.
right, it's 3 to 5 times higher than what you would find normally circulating in your bloodstream.
Okay, so if the estrogen-deficient lamina propria is this dried-out, abandoned neighborhood we talked about, injecting calcium chloride-activated PRP is like dropping in a team of elite architects who immediately open their toolboxes.
Yes.
And the toolboxes are the alpha granules.
That is a perfect way to look at it.
So the toolboxes are open.
Yeah.
But what is the very first thing these growth factors do to bring this degraded tissue back to life?
Well, you have to restore the supply lines before you can rebuild anything, right?
Right.
The tissue desperately needs oxygen and nutrients to fuel any further repair. Which leads us to the first major signaling cascade highlighted in the studies, which is VEGF.
Vascular endothelial growth factor.
Exactly. PRP is incredibly dense with VEGF, and its primary function is angiogenesis.
The creation of new blood vessels from pre-existing ones.
You got it.
But how does a chemical just floating in plasma actually convince the body to build a new blood vessel? I mean, it sounds crazy.
It's basically a biochemical domino effect. VEGF molecules seek out and bind to very specific receptors on the surface of endothelial cells.
And endothelial cells are the ones that line the inside of the blood vessels.
Right. And the sources really emphasize one specific receptor called VEGF-R2.
Okay, so when VEGF binds to this VEGF-R2 receptor, the studies say it triggers phosphorylation. Can we break that down?
Yeah, sure. Phosphorylation is basically how cells pass messages internally. When VEGF binds to the outside of the receptor, it changes the physical shape of the receptor.
Like a key in a lock.
Exactly. And this shape change allows the receptor to grab a phosphate molecule from inside the cell and attach it to another protein.
Oh.
And that attachment changes the electrical charge of the next protein, which wakes it up, allowing it to tag the next protein.
So just a chain reaction going
Yeah.
straight down into the cell's nucleus.
Right, a very rapid chain reaction.
And what's the actual message that reaches the nucleus at the end of all this?
It commands the endothelial cell to do two specific things: migrate and proliferate.
Oh.
Yeah, the cells begin to multiply rapidly and literally stretch out toward the highest concentration of the VEGF signal. They link together and hollow out to form brand new microscopic tubes.
And the sources also mentioned that VEGF has a partner here, right?
Yeah, platelet-derived growth factor.
Yeah.
Or PDGF. The literature is very clear that these two operate synergistically.
So what does PDGF do?
Well, PDGF helps stabilize these newly formed blood vessels so they don't just, immediately collapse.
Right.
Together, they facilitate rapid neovascularization, bringing all the oxygen and nutrients that are strictly necessary for cell regeneration.
Okay, but wait. I mean, if the systemic estrogen is still completely missing in the patient's body, doesn't this new blood supply just eventually collapse again?
That's a really good point.
How does a local injection create a lasting structural change if the hormone environment hasn't changed?
It's a completely valid question, and it's the exact hurdle researchers had to clear. Because you're right, a blood supply alone isn't enough to fix the tissue permanently.
Right, because the surrounding tissue is still degraded.
Exactly. If you just lay down new blood vessels but the scaffolding is still weak, the vessels regress. You have to actually rebuild the structural scaffolding of the lamina propria so it can retain moisture and elasticity on its own.
Okay, so how does it do that?
That requires the next major cascade, TGF-beta.
Transforming growth factor beta.
Yep.
So if VEGF laid the plumbing, TGF-beta is building the actual physical structure.
Exactly. While VEGF gets the blood flowing, TGF-beta is the master regulator of the extracellular matrix.
Which is the physical foundation.
Right. So for a condition like vaginal atrophy, where the thinning of the tissue is causing just severe discomfort, this TGF-beta cascade is really where the regenerative magic happens.
Let's focus on the moisture aspect first.
Yeah.
Because severe vaginal dryness is arguably one of the most debilitating symptoms of GSM.
Absolutely.
How does TGF-beta physically rehydrate this totally barren tissue?
Well, TGF-beta operating alongside PDGF and something called basic fibroblast growth factor.
EFGF, right?
Yeah, it initiates this cascade that targets the local cells and upregulates a very specific enzyme known as hyaluronan synthase, or HAS.
Gases.
Yeah.
So it's like, think of hyaluronan synthase as a microscopic manufacturing plant embedded right in the cell membrane.
That is a highly accurate way to visualize it, yeah.
Yeah.
TGF-beta acts as the biological signal that just flips the switch.
Telling this factory to turn on.
Telling this HAS plant to go into overdrive, yeah. The enzyme starts rapidly weaving together simple sugars from inside the cell to form long, complex chains of hyaluronic acid. Right? And then it physically pumps them out into the extracellular space.
Here's where it gets really interesting. The body is essentially manufacturing its own internal moisturizer.
Yeah, exactly.
Because, I mean, we constantly see hyaluronic acid marketed in expensive skin creams and serums, but in this case, the PRP is just giving the local cells the exact chemical instructions they need to produce it themselves.
And because HA is so hydrophilic, it immediately starts pulling water back into the lamina propria, which naturally relieves the atrophy symptoms. It fundamentally changes the tissue's innate ability to hydrate. But TGF-beta's job doesn't end with just moisture.
Right, because we still need the physical scaffolding.
Right. It also drives the synthesis of the solid structural components of the extracellular matrix.
Like the collagen and elastin.
Yes. TGF-beta targets fibroblasts, which are the most common cells in connective tissue, and it just commands them to churn out massive amounts of collagen.
Any specific kind?
Yeah, very specific. It stimulates type I collagen, which provides tensile strength so the tissue doesn't tear easily, and type 3 collagen, which provides the elasticity.
And the sources also detail the production of laminin and fibronectin during this cascade.
Right. Those are vital glycoproteins. You can think of them as the biological glue. They bind the collagen fibers, the hyaluronic acid, and the cells together into this cohesive, stable matrix.
I really wanted to talk about the visual evidence from the OVX rat studies here because seeing this on a cellular level is just so fascinating.
It really is striking.
When researchers actually put this treated tissue under a microscope, what were they looking at?
Well, they use these special chemical stains that basically light up specific proteins under a microscope. It lets them see if the tissue architecture is actually changing.
Right.
And after the PRP installation, they observed this massive, concentrated increase in a protein called alpha SMA.
Alpha smooth muscle actin.
Yeah, alongside laminin. They found it tightly gathered in myofibroblasts and in the microvessels right beneath the urothelial basal layer.
So right in the lamina propria.
Exactly. And when they compared this to the untreated estrogen-deficient rats, where that entire area was basically dark and depleted.
The distance was huge.
Stark. The microscopy proved that the PRP didn't just mask the atrophy symptoms, it literally laid down a totally new cellular foundation.
Layer by layer.
Layer by layer.
Okay, so we have VEGF triggering the new blood vessels, and TGF-beta aggressively pumping out hyaluronic acid and collagen, thickening up the vaginal wall.
Right.
But wait, if TGF-beta is so aggressively building all this collagen and tissue, why doesn't it just overshoot? I mean, why doesn't this turn into a giant stiff scar?
That is the big question.
Because too much collagen production is the exact definition of fibrosis, right?
You're completely right to point that out. This is perhaps the most elegant and honestly counterintuitive mechanism in the entire PRP process.
Because usually TGF-beta is the bad guy when it comes to scarring.
Exactly. When TGF-beta operates unchecked in the body, it is the primary driver of pathological scarring and fibrosis.
And in the vaginal wall or anywhere in the pelvic floor, stiff scar tissue is the absolute last thing a patient wants.
Right. They're looking to regain elasticity, not lose it.
So how does it avoid scarring?
This is where the biological braking system within PRP reveals itself. The experimental data shows this really surprising mechanism. While PRP uses TGF-beta to build tissue, it simultaneously prevents the differentiation of fibroblasts into the specific rogue myofibroblasts that cause fibrosis.
Wait, how does it do that?
It does this by negatively affecting something called the TGF-beta1 SMAD3 mediated signaling pathway.
The SMAD3 brake.
Okay.
Let's slow down and unpack this SMAD3 pathway. Because we just said TGF-beta is the good guy building the tissue, how does it stop its own signaling from going too far?
So it achieves this by intercepting the internal messaging system of the cell. SMAD3 is a specialized messenger protein.
Okay.
Normally, when TGF-beta binds to the outside of a cell, it tells SMAD3 to travel into the nucleus and turn on the specific genes that produce massive chaotic amounts of collagen.
The kind that forms stiff scars.
Exactly.
So if TGF-beta is the gas pedal for tissue growth, SMAD3 is like the physical linkage connecting that pedal to the engine.
That's a great analogy. And the components within the activated PRP through this really complex feedback loop essentially put a block on that SMAD3 messenger.
They cut the linkage.
They cut the linkage. So the tissue receives the initial signal to build healthy, structurally sound collagen, but the specific intracellular signal that causes overproduction and fibrosis that gets chemically dampened.
That is wild. So the plasma contains both the instructions to build and the specific biochemical inhibitors to ensure it doesn't overbuild.
It's perfectly balanced, and that safety mechanism is actually reinforced by macrophages, too.
Oh, right, the immune cells.
Yeah. We noted earlier that PDGF helps stabilize blood vessels. Well, PDGF also drives the chemotaxis, the chemical attraction of macrophages to the injection site.
Normally, macrophages are just the cleanup crew, right? Eating cellular debris.
They do clean up the degraded tissue left over from the atrophy, but these recruited macrophages are also prompted by the local environment to secrete their own highly regulated localized amounts of TGF-beta.
So they act like on-site biological supervisors.
Exactly. Just ensuring the regenerative cascades stay perfectly balanced, building new tissue while actively suppressing the pathways that lead to chaotic scar tissue.
Wow. So what does this all mean for the patient? I mean, connecting these microscopic SMAD3 inhibitors and VEGFR2 phosphorylations directly to the real-world relief of genitourinary syndrome of menopause.
Well, for the patient sitting in the clinic, this cellular choreography translates into a macroscopic restoration of tissue function.
Right, real relief.
Exactly. Because the Hyas enzymes have pumped hyaluronic acid back into the lamina propria, and the new blood vessels are actively sustaining it. The severe vaginal dryness is reversed.
And because the type I and type 3 collagen ratios are restored.
Right. Without the stiffening effect of SMAD3-driven fibrosis, the tissue literally regains its physical stretch and resilience.
Which directly addresses things like dyspareunia or pain during intercourse, which we know is a massive quality of life issue for patients dealing with GSM.
It drastically reduces that pain. It restores the structural support for the pelvic floor, which can even alleviate associated urinary urgency or incontinence.
It's a fundamental return of function to a tissue that was just wasting away due to estrogen deprivation.
It truly is remarkable when you zoom in on the mechanics.
So let's briefly recap this incredible journey of the autologous PRP from start to finish.
It really is a masterclass in biological engineering.
It starts with the patient's own blood, isolated down to a concentrated plasma. The introduction of calcium chloride acts as the spark, mimicking an injury and initiating the thrombin cascade,
which physically bursts open the platelets,
releasing the alpha granules and their massive payload of concentrated growth factors.
And then VEGF and PDGF take over. They seek out the VEGFR2 receptors on endothelial cells, trigger that phosphorylation cascade, and lay down an entirely new network of blood vessels,
bringing oxygen back to the barren tissue.
Right. Followed immediately by TGF-beta acting as the master architect. It flips the switch on hyaluronan synthesis to pump out moisture-retaining HA.
And directs fibroblasts to lay down a fresh elastic matrix of type 1 and type 3 collagen.
All while PRP's internal braking system actively blocks the SMAD3 messenger pathway,
ensuring that this flawless reconstruction of the estrogen-deficient lamina propria happens without a single trace of fibrotic scar tissue.
It relies entirely on the body's innate ability to read its own biochemical blueprints.
Which honestly leaves us with a rather profound final thought to ponder today.
Oh.
Yeah. If a localized injection of autologous PRP can orchestrate such incredibly specific, perfectly balanced cascades, triggering angiogenesis and deep tissue regeneration without scarring in a degraded vaginal wall, could we eventually map and manipulate these exact growth factor ratios?
That's a huge question.
Right. Imagine if we could use those MAP ratios to reverse estrogen-dependent aging in other organs across the body.
Wow.
Could we entirely eliminate the need for systemic hormone replacement therapy by simply providing the local cells with the exact molecular instructions to rebuild their own scaffolding?
Something to think about.
Definitely something to explore on your own. Thank you so much for joining us on this deep dive, and keep exploring the incredible biology of your own body.